So I welcome each one of you to this session on surgical retina. It's a potpourri of the common vitreoretinal pathologies that we deal with in daily life. This is a video-based course. When I was given the chance to be the chief instructor for this course, I thought about what is it that I can do differently. Instead of having a routine presentation, I thought we would show a single case that we deal with of a particular vitreoretinal pathology which forms the bread and butter of our practice. So as we go along the course, each one of us, all of them my illustrious presenters who have more than 15 years experience as VR surgeons, we will try to look at why a surgical option was advised for the particular patient, the preoperative surgical planning that went into doing that case, the intraoperative customization of the surgical strategy, and most importantly, the postoperative management and the final visual results. We have Dr. Mahesh Gopalakrishnan presenting on vitreomacular interface pathologies. My presentation will be next on membrane surgery in PDR. Dr. Lalit Verma will be presenting on why he opted for surgical management in his case of diabetic macular edema. Dr. Prabhu Shankar will be speaking on rhegmatogenous retinal detachment with PVR in his case. And we will conclude with the nuances of treating endophthalmitis by Dr. Thomas Cherian. I invite Dr. Mahesh to come up onto this podium.
Thank you, Meena Madam, for giving me this opportunity to present here. So, even though I will show a single case video of one macular hole and one ERM, but there are other factors deciding the surgery and intraoperative management. So, I will discuss few things about that. We all know that vitreous is a gel with 98% water. And in fact, most of the vitreomacular interface diseases are due to anomalous PVD. So there is a normal PVD occurring in everyone, where there is a separation, gel contraction and liquefaction, followed by separation of the gel from the retina. When there is a mismatch, that means if the gel contracts and does not release from the retina, it causes VMT. If the gel contracts and leaves some part anomalous separation, it causes ERM, like that. So it is a mismatch of or anomalous PVD that causes the group of diseases which is classified by International Vitreomacular Traction Study Group. So this is the pathology, starting from epiretinal membrane, macular hole, VMT syndrome, and some pathologies in RD and vitreopapillary retraction. So I will show one by one a few cases and then one surgical video. So this was a case of VMT. This is actually in the classification IVTS, there is a VMA, vitreomacular adhesion and vitreomacular traction. When the vitreomacular traction comes, there is a distortion of the foveal contour, resulting in symptoms of defective vision and metamorphopsia. So we operate the patient when there is both of these, the defective vision and symptoms, metamorphopsia is there. So this case is done well with postoperatively with improvement of 6, 12 and 10. It is very difficult to counsel the patient regarding the outcome of ERM and VMT because symptoms may not go completely. This is another case where there is a distortion, there is a vitreomacular traction, and this was managed by cataract surgery along with vitrectomy, but following that it became a full thickness macular hole. So these things can happen occasionally in VMT cases. And after 2 years when I saw the patient, this hole has closed spontaneously. So this we have published as a case report in IGO. So this sort of variable outcome is very common in VMT that mandates your need for communication with the patient. That is a challenge in these cases, when to select the cases in VMT, when to operate, and what can be expected from the treatment. So, but some cases like this do very well. There is a VMT, preoperative and postoperative, patient has done quite well. So operate when the patient is symptomatic, and good communication is a must. So this is the thing that I want to stress in VMT cases. Now, going to the next stage, that is macular hole. When the VMT becomes more, it can result in macular hole due to tangential and anteroposterior traction. Some of the early macular holes can close, like an acute PVD resulting in something like this. It can close. Within around 20% cases can close. So, but if it is not there, we have the standard of care, that is a surgical treatment. So, if the macular hole is the treatment for macular hole is standard now across the world, that is vitrectomy, internal limiting membrane peeling with gas, and extra procedures depending on the size of the hole. There were some controversies initially whether prone positioning is needed, but this Cochrane database meta-analysis shows that prone positioning in the initial few days, a couple of 2 or 3 days or 4 or 5 days maximum, is helpful in closure of the eye. Then there are studies which showed whether ILM peeling is needed or not. But the meta-analysis in Cochrane database showed that the ILM peeling does help in the closure and better outcome. So now these are not controversies, these are standard procedures. So we analyzed around 697 eyes done over 10 years, and we had a closure of 89.2% when the minimum linear diameter, the hole size is called minimum linear diameter. Base will be more, the diameter is less. So minimum linear diameter is less than 400. And above that, the success rate reduces, and above 800, it is little less. So this is our results, and the take-home message is, if the hole size is more than 800, we need to do extra procedures like inverse ILM flap or some transplant, retinal transplant, amniotic membrane. There are a lot of methods, whichever is convenient with you. So there is no contraindication other than whether some chronic holes and some patient factors like age and comorbidities in selecting a macular hole. Otherwise, we do operate most of the macular holes, and the prone position is needed only in the first couple of days. Now, this is standard procedure. I will show the video. So initial first step is always PVD induction. In macular hole, there will not be any PVD usually, except in very rare cases. So you have to induce the PVD. We can use a chromatic vitrectomy using tricoat, and that has to be separated completely. I have mixed a few videos to show the PVD induction. You have to catch the posterior surface of the hyaloid and then pull, then only it will separate. Once it is separated, it is easy to trim the vitreous till the periphery just by rollback technique. Next step is stain the macular hole and then ILM peeling. Stain the ILM and then ILM peeling can be started. The standard treatment is pinch and peel. You have to pinch the ILM, and then peel it around the hole. So this is a standard technique. There are different methods. Loop is there, Finesse loop, lot of things are there. This is another case. Since this is not a surgical retina meeting, I am not going into the controversies and all. So this is a standard method. Peel it across with pinch and peel. There are different shark skin forceps is there. Now other methods are there. But if a person with high myopia and less stereopsis like me can peel easily, anybody can peel. You don't need anything. So this is a pinch and peel. Okay, so once it is over, you can do a fluid air exchange, and usually we put a small SF6 or some gas like that. Usually I give SF6. So this is a standard. I am not showing the controversial other things, just a standard macular hole surgery. So after that, fluid air exchange followed by prone position. So this is a standard step. There are different studies published by us, timing and outcome of surgery for, so if the hole is not closing, if you do early resurgery, many of them close. Then comparative analysis, internal limiting membrane, too much peeling is not needed. A small area is around the hole is enough, which, so that is another study published by us. Then a lot of unnecessary ILM peeling also will cause microcystic changes and damage in the retina. Sulfur hexafluoride and C3F8 doesn't have any difference in macular hole. So these are some of the considerations that published by us in retina. Other developments I told, inverted ILM flap and stuffing, etc. But the evidence is confined to case series only. So any macular hole can be treated other than that one few I told. Coming to epiretinal membrane, American Academy, the articles and recommendations, they show that the outcome is little unpredictable in epiretinal membrane, and you can, the eye with very poor vision initially will not improve much. Eye with little better vision improves much, and the vision can improve over time up to 6 months or so. So they have studied few systematic review, and in ERM, it is extremely important to communicate with the patient. Who is a good candidate for surgery? Symptomatic patient, reasonably good vision, 2 meter, 3 meter, very chronic and gross distortion of the macula, they are not very good candidates because they will never be happy. So this was a case where there is pre-op case. This is the pre-op, and intraoperative factors, standard, same thing. You can, usually in this case, PVD will be there. So using tricoat, then stain with brilliant and remove the membrane. Usually this will not come that easily like a ILM. Piecemeal it will come, and then you can stop whenever you are doing damage to the retina. And this is post-op, quite okay. But in some other cases, the post-op, they will not be, I am just finishing, they will not be very happy because the distortion of the outer retina and the vision may not be very good. Like this case, even though it would look nicely post-op, patient was very unhappy in spite of having 6/9 with anisoconia, so the size difference and all. So this is the okay. So take-home message: if the operate, if there is documented worsening and symptomatic, ideally 612 to 660 is ideal, and poor initial vision means poor final vision. Management of cataract is another topic along with the surgery. Proper communication and with the patient is absolutely mandatory. Thank you, madam.
Thank you, Dr. Mahesh. Our session has very little buffer time, so we'll straight away go into the next talk. Dr. Meena Chakravarti will be presenting on diabetic vitrectomies, proliferative diabetic retinopathy with tractional retinal detachment and vitreous hemorrhage. Over to you, Dr. Meena.
There are a lot of things that we know about diabetic vitrectomy. The primary indications for this procedure, the principles, basic principles of membrane surgery, the choice of tamponade agents, and some of the relevant post-operative complications. And there are some things which are new, which includes the use of intraoperative OCT, heads-up surgery, the ever-expanding indications for vitrectomy, and use of adjuvants to enhance the final results of vitrectomy. So my patient is a 46-year-old male. He is a chronic diabetic of 15 years diabetic age with poor diabetic control. He is a hypertensive, but fortunately has a normal renal status. He has already undergone 2 sittings of pan-retinal photocoagulation and 1 anti-VEGF injection, and the duration of his defective vision cannot really be pinpointed. It could have been for years. Why did I choose a surgical option for this patient? Because of his poor vision, and he had a dense carpet of preretinal membranes, underlying which was a total shallow retinal detachment, and he had a stable lasered fellow eye. This is a preoperative fundus appearance of the patient of the right eye and the fellow left eye. He underwent a thorough preoperative assessment, which included both ocular and systemic. There is no point in doing a 2.5 hour long vitrectomy in a patient who has a poor renal status and whose lifespan is very short. As with most of us, my technique is also to under-promise and over-deliver. The do's and don'ts of silicone oil tamponade, the need for positioning in the postoperative period, the need for subsequent cataract surgery and silicone oil removal. A preoperative biometry was done. A suboptimal vision through silicone oil was conveyed again and again to the patient. Emphasis on diabetic control. And we underscored the need for periodic evaluation to evaluate for progression of the disease, and he was also told about the compliance to postoperative follow-up. So this is a surgical technique. I thought I would add a little color to it by giving it a voiceover and music. Membrane dissection is one of the major components of a complicated diabetic vitrectomy. A variety of techniques such as delamination, segmentation, and en-bloc excision have been used to clear the retinal surface of proliferating membranes. This video demonstrates how a combination of maneuvers can be employed to dissect an extensive and adherent membrane in a 46-year-old chronic diabetic with advanced proliferative diabetic retinopathy. The membrane dissection is started inferiorly after excising all vitreous attachments to the edges of the fibrovascular proliferation. A 23-gauge knife spatula is used to sever the vascular nails anchoring the fibrovascular proliferation to the underlying retina. When the membrane has loosened sufficiently, it is segmented with a 23-gauge cutter. The presence of vitreoschizes and additional membranes are most common in diabetic retinopathy. In the nasal quadrant, the additional membrane is excised and the fibrovascular proliferation is peeled away from the optic disc. Dissection is resumed in the supratemporal area. After excision of all loose membranes, using a blunt spatula, an area of cleavage is identified and the 23-gauge cutter is used to segment the membrane into two halves. The lower half is dealt with first. The upper half is segmented into smaller areas and two densely adherent bits are left behind. Perfluorocarbon liquid is used to iron out the retina, followed by N2 laser pan-retinal photocoagulation, a perfluorocarbon liquid silicone oil exchange, thereby stabilizing the retinopathy process. The fundus picture taken on postoperative day 15 shows a stable and attached retina and a significant visual recovery. So this patient did have a significant visual recovery under silicone oil with a hyperopic correction. His postoperative care included zealous use of topical steroids, mydriatics, and cyclopedic. We did our best to prevent anterior segment reaction, post-vitrectomy fibrin, and posterior synechiae formation. He was cautioned on the need for postoperative positioning, and the duration of positioning was shortened of the first week of the postoperative period. A control of intraocular pressure was meticulously adhered to. The schedule of follow-up for this patient was every weekly for the first 1 month and every 2 monthly silicone oil removal. So he did well with follow-up, and at each visit his best corrected visual acuity, tonometry, slit lamp examination, everything was done. At 3 months down the lane, he developed a significant about 3+ nuclear sclerosis and a posterior subcapsular cataract, where we did a combined phaco-IOL silicone oil removal. His best corrected visual acuity post-operatively was 6/18, and IOP was maintained at 16 millimeters of mercury. The follow-up still continued. We look for recurrence of the fibrovascular tissue from the anterior hyaloid, post-vitrectomy glaucoma, neovascularization, etc. And in the process, he developed the open-angle stage of neovascular glaucoma. His pressures were poorly controlled with anti-glaucoma medications. His best corrected visual acuity dropped from 6/18 to 5/60, and his IOP was 40. I did an Ahmed valve implantation at 4 months post-silicone oil removal with intravitreal bevacizumab. Thus, you can make out a small bubble of silicone oil happily resting on the valve, on the tube of the valve. This is his last follow-up picture. He is doing quite well. And let me not let go of this opportunity to canvass for my husband. Please support Arup in his endeavor. He's standing for the post of Vice President of the AIS election in 2024. I thank you very much for your patient hearing.
Thank you, Dr. Meena. We have Dr. Lalit Verma, one of the tallest vitreoretinal surgeons in India, the past president of AIOS. He'll talk to us on a less studied field, that is vitrectomy in diabetic macular edema. Over to you, Lalit, sir.
Thank you for including me into this wonderful program on surgical retina. Unfortunately, not many people are interested in retina, and very few people are interested in surgery of retina. Dr. Meena showed a wonderful videos on PDR. PDR primarily, either is laser or surgery, but DME is primarily injections and injections and injections. So where to fit in surgery, I'll just try to, talk about it. DME is not a single entity. You can have myriads of presentation. So you can't have a single approach in management of DME. And there are multifactorial, issues here. Hyperglycemia, hypertension, lipid profile, litazone, sleep apnea, so many factors are involved in DME. So management today, diagnosis is not very difficult at all. And previous terminology based on thickening has been overruled by terminology from OCT. And as first contact of patient, I always will do an FA or OCTA and an OCT. You see, and parameters to be considered once you are managing DME is always 3 factors together. That is vision in combination with FA picture, in combination with OCT. Why FA? Because FA will tell you a huge amount of findings, which will include CNP areas, neovascularization which have not been discovered, plus also focal leaks. The role of OCT, apart from categorizing various types of edema, cystic or in IRF and SRF, most important role of OCT is to rule out tractional DME, because these are the patients who may not respond to all these injections. So DME, the original classification based on thickening, and OCT classification based on center involving or non-center involving DME. What I like to do is take the best of all these things and classify into tractional DME, and tractional DME could be without vision loss or with vision loss. Then non-tractional DME could be again center involving or non-center involving. The reason I am categorizing it, because non-center involving means you have to do laser, whereas it's center involving, you have to depend on pharmacotherapy. Then there could be issues of combined, where you have tractional plus other factors playing a part. So if there is a tractional DME based on the OCT findings and your examination, this could be, as I said, without vision loss. If it is without vision loss, the best thing is observation. Do not unnecessarily go inside and remove membranes. So this is a classic example. This lady I am following up for last more than 8 years now, one-eyed lady, maintaining good vision, although she has traction, but predominant traction is on the nasal side. Please do not go inside and do vitreous surgery in such patients. Whereas if it is tractional with vision loss, then the answer is surgery. MIVS has made the job much easier. However, sometimes you can, do 1 or 2 injections in these patients, like I did in this patient. This patient is a diabetic, has this kind of edema. and Dr. Mahesh showed wonderful videos of VMT. So in this patient, what happened was a spontaneous VMT or which was aided by injection. You see, any injection in the vitreous cavity has the propensity to lift off this hyaloid phase. So this is what happened in this patient. Intravitreal injection was given of Razumab, and this patient had a foveal contour. So I'm not saying that all tractional patient but 1 or 2 injections you can try. You may be lucky that you may have this result. But tractional DME with visual loss, believe me, general answer is surgery. And surgery in today's time is very, very simple MIVS surgery. Not like the complex surgery which Dr. Meena showed. Here we do a core vitrectomy, which is followed by engagement of the hyaloid, which is very nicely visible with the help of tricot, what Mahesh also showed very nicely. And once you have engaged this hyaloid, after that you can increase this suction of this. And you see, this is the macula of this patient after you have removed the hyaloid. And since the cataract was increasing, a lot of these patients who require macular surgery, we combine with the cataract surgery also. So we called in the cataract surgeon. He did a nice phaco job. Once the lens was out and IL was placed inside, then what I did was, tricot had already been done. We stained this membrane. I am very fond of staining these membranes because staining adds precision to your dissection. So under air, I will put 1 drop of trypan blue, which will nicely stain the epiretinal membrane. And then take this 25 gauge MVR blade, which is slightly old, not a very sharp MVR blade, because this will act like a small pick. And then you identify this membrane, lift the edge, and then this can be completed with the help of Eckhard forceps or any end opening forceps. And since the macula was not looking very good, I injected a 3rd dye also, that is the BBG dye now, which then this is the ILM membrane which has been stained here, and then peeled the ILM also. So both the 3 dyes were used, tricot, the trypan blue as well as the BBG. This was the end of surgery. The tamponade was only air. We didn't use any SF6. We didn't use any C3F8 in this patient. So this was the end of the surgery. And this was the result of this patient. You see, pre-operatively it was like this, and then it is post-operatively. Foveal contour may take some time to recover. This is another example of a DME which is combined detachment. Here we have a tractional DME plus a reg RD added to it. So this was the result of this surgery after the surgery. This was the post-op picture. Above is the post-op OCT and below is the pre-operative OCT showing a combined detachment. So thus to conclude, this is what I spoke about the tractional DME. So even in non-tractional center in volume DME, where the hallmark is basically anti-VEGF injections or steroids or laser or combination. So this is the main treatment. But there could be some recalcitrant patients, say around 5 to 10%, who will not respond to either of them. So in such situations, once you are fed up of trying all this, you could consider doing MIVS. Because literature says that several studies have shown the benefit of MIVS, not only in eyes with traction, but also in eyes without traction. Although the visual results in patients without traction are much, much less compared to with traction. So, ladies and gentlemen, diabetic retinopathy or DME is today not only injections. You could select your patients based on the information of FA and OCT and offer these patients, especially in tractional DME, the benefit of doubt with MIVS. Believe me, results are good and you put an end to all the injections. So this is the last slide where I said tractional DME. Answer is PPV, but even in non-tractional DME, after you have exhausted all possibilities and ruled out everything, you could consider PPV or in a combined detachment. Thank you very much for this opportunity.
Thank you, sir, for that very nice talk. I request Dr. Prabhu Shankar to come up to the podium. He'll be speaking on ecbetogenous retinal detachment complicated with proliferative vitreoretinopathy.
Thanks, Meena madam. Okay, once regmatic RD is there along with PVR, so your surgery is always going to be complicated. Basically, two types of classifications are there. So the A, I mean, so it's grade A, grade B, C, and D. So usually once you see as C and D, so things are going to be more complicated and mostly will end up with extensive retinal surgery. So another one classification shows that where the fixed retinal folds are there, whether you're more dealing with posterior folds or folds anterior to the equator. So another type is there where it depends whether the folds are focal or diffuse or subretinal or circumferential or more anterior in the vitreous base. So I'll just show a couple of videos how we manage some of the cases. This is a patient with RD with CD with PVR. So we need once there's a significant CD all around 60 degrees, probably you have to take a decision whether you want to drain the choroidals and then proceed with the vitrectomy. So after the core vitrectomy is over, so just do a small sclerotomy around 8 millimeters from the limbus or where you see the CD was more dominant. And just with the MBR blade there, make a small slit and you can just drain off the fluid, a very simple procedure. And once you have, know that CD settled down, then you can see a fixed retinal fold right in the inferior 6 o'clock position with a break there. So you need to gently remove off that membrane star fold there, then try to extend the vitreous base dissection beyond that star fold. So sometimes very difficult to go up to the aura. And so once that traction is completely released, and just check all the peripheral retinas, all 360-degree quadrants, and everything's fine, then you can go in for a fluid air exchange. So make sure that your cut rate is low and maximum cut rate of very minimal vacuum because you shouldn't catch up the retina there. So that's trimming that anterior this thing and just drain the fluid there. So I'm going for fluid air exchange. So it's all been assessed by PFCL. So our big advantage of PFCL is it prevents you, it helps you in dissecting the peripheral retina without much traction to the peripheral retina when they're jumping. So once your retina is well settled, you can just go ahead with the laser. The second case, you can see very bullous detachment with quite an extensive PVR in the inferior quadrant. So after putting PFCL, try to remove the break. So you can see the temporal break there, another large PVR fold, a lot of traction. So even this, we can put the PFCL up to the area where the break is there so that if you try, in case you put excess fuel, it might go under the break. So up to the break, fill the PFCL. I'm just draining the subretinal fluid. So you can see the retina going back. So now you can identify the break better. So just check the other quadrants. So once, just try to trim all those flap tires there. So here I couldn't remove the inferior PVR more anteriorly. So I just done inferior small area quadrant retinectomy. So make sure you cauterize. So once you cauterize, just whichever area the retina is totally fibrous, just extend the dissection. Always you have to do, whenever deciding to do a retinectomy, you will have to go into the normal retina. Make sure you remove all that fibrous retina. Once you feel the traction is relieved, then try to do the laser. So make sure you treat all the retinal breaks wherever it is. CD is still not fully settled, but it's in a bit that goes up post-operatively. So drain the fluid completely. So I don't do a direct PFCL oil exchange. Always I go in for air and then go. Complete of the laser. Make sure that retina is well attached. Make sure all the membranes are close to the anterior aura are removed completely. Once you do adequate laser at or 3 to 4 layers of laser barrage, then you can go in for the oil. The case 3, another case with a closed funnel RD. So here, once closed funnel, you're not able to visualize the optic disc. So you can see there is already crumpled up there, and you can see the macular pigments there. That's how you differentiate where the macula, yellow pigmentation is there, show the macula. So probably a membrane is right there, over the disc and the macula. Try to grasp that gently and remove that membrane. Once you remove that membrane, the funnel starts opening up, and try to trim the vitreous as far as possible. Once your vitreous dissection is quite adequate, then go in for a PFCL. So now you can see the funnel opening up. You can able to visualize the disc and the macula. So keep trimming the vitreous as far as possible. Only thing is, you not create, already have retina, there are a lot of breaks there. Make sure you don't create new iatrogenic breaks. So keep injecting the PFCL slowly up to the edge of the breaks. Once you've done adequate vitreous brace trimming, you need to identify where all the breaks are there. Remove all the membranes around the breaks. So you can see that removing all the vitreous adhered. Trim the vitreous base. So you can keep injecting gently the PFCL if you feel want to settle. See, now I'm marking all the peripheral retinal breaks there. Identify the breaks with cautery. And then once you go in for the fluid air exchange, the retina well settled, then just laser the peripheral retina where all the breaks are there, preferably ideally to do a 360-degree barrage. This patient has been assisted by a belt buckle also. In case the extensive PVR is there, that you can always go with the belt buckle along with the vitrectomy. The last case. This patient also had an extensive retinal detachment, so a belt buckle has been placed and a large infusion cannula. Here the patient didn't have a PVD. So what we have done is, we have stained the posterior vitreous. So now gently we need to see where the posterior hyaloid is there. So with Tramslone assisted staining, you are able to delineate the posterior hyaloid from the retina. So gently lift it up. Once you clear the central core vitreous and the posterior hyaloid, then the retina opens up nicely. So slowly, gently trim the. Now inject PFCL. So you push all the retina subretinal fluid from the breaks. Then identify all the breaks, do a very small trimming. This patient had a large tear, supranasal tear. So identify all the edges of the tear there, because sometimes under air you will not be able to see. So once you fill the PFCL up to the edge of the tear, you can complete the laser with the PFCL or go for a fluid air exchange, then do the laser, and then you can just go in for the oil. Thank you.
Thank you, Prabhu, for that very elegant presentation on one of the most difficult surgeries that we perform daily. I request Dr. Thomas Cherian to come up to the podium and present on the nuances of managing endophthalmitis.
Thank you, Dr. Meena, and good afternoon. Endophthalmitis vitrectomy is always a distress vitrectomy. We deal with three types of endophthalmitis: postoperative, traumatic, and endogenous endophthalmitis, and here we'll be discussing cases of postoperative endophthalmitis. Pain is one important pathognomonic feature of postoperative endophthalmitis, though it's not mandatory that a patient should have pain. Drop in vision in the postoperative period, that means a patient who had 6/6 on the first postoperative day, dropping to 6/18 or 6/36 in the next subsequent days, always have a strong suspicion of endophthalmitis. We always have had a discussion of endophthalmitis versus TAS. We start with topical and systemic antibiotics, steroids and cycloplegics in a TAS, but don't wait indefinitely with the wishful thinking of a TAS. Always err on the side of an endophthalmitis. Once we make a reasonable diagnosis of endophthalmitis, we inject intravitreal antibiotics and antifungals and maybe steroids. But again, if the patient does not show any sign of improvement in the next couple of hours, always take the patient up for vitrectomy. EVS was done almost 3 decades back, and we have gone much ahead of the EVS situation when vitrectomy was not as safe a procedure as it is today, and we have much better antibiotics for intravitreal use and systemic use today. When the exudates in the vitreous obscure a fundus view, nowadays we take up a patient for vitrectomy and not look for a finger counting or a hand movement or a vision less than 1/60. Also, if there is a worsening or if we don't find an improvement in the fundus view following an intravitreal injection, that case is a case for vitrectomy in endophthalmitis. I'll go through 2 cases. This is my first case of endophthalmitis. This is a fulminant case. Do a 23 gauge vitrectomy here. Clear the vitreous gently so that not to induce much traction, not to induce any break. That is important. The retina is very friable in these cases, unlike the normal pristine retina. These friable retinas are very prone to create breaks, and once you have a break, then the entire prognosis changes. So do a very careful vitrectomy, cut slowly, especially when you go to the periphery, and also when you induce PVD also be very slow. Those bubbles just behind the IOL that are indicative of residual vitreous, even while you are proceeding with your vitrectomy, if you see those water bubbles or air bubbles just behind the intraocular lens, that means you have residual vitreous here. Go ahead and clear that and gently induce a PVD. Again, be careful not to create a break. There are a lot of exudates on the retina. It might tear any time. Do a good dissection, clear up wherever possible. And once you clear, your vitrectomy is done. The next question is whether to inject oil or not. We, of course, inject silicone oil when the retina is found to be unstable, and silicone oil also seems to be protecting the retina and controls endophthalmitis to a large extent. So more often than not, I would inject silicone oil if the retina is unstable in some way. I don't ever look for a break or a detachment, but while you do the vitrectomy, if you find that the retina is fluttering in the periphery, again, for me, that is an indication for injecting silicone oil, but again, not in 100%. And once you complete the vitrectomy, you inject your intravitreal antibiotics. Yeah, you inspect for any breaks, pull out the ports, pull out the first port here. Here I am injecting the antibiotic through the trocar cannula system. But before injecting the antibiotic, always shut off the infusion port, otherwise what you have injected might immediately egress out. IOL explant is another matter to be decided. If you have a sufficient view of the fundus while you are doing a vitrectomy, you leave the IOL there. If the fundus view is not good, or if you have a very strong suspicion of a fungal endophthalmitis, you can explant the IOL. This is my second case of endophthalmitis, which is a low-grade endophthalmitis. This patient presented with an endophthalmitis in the postoperative period. I am always doing a vitrectomy under the subtenance block. And for that matter, all my vitrectomies are under a subtenance anesthesia. Again, I measure all this. The old habits of doing squint surgery still persist while I measure and go in with the trocar cannula. This is a 23 gauge vitrectomy. Low-grade endophthalmitis where the patient presented with 1/60, injected intravitreal antibiotics, waited for a week, it improved up to 6/60. Again for a week, it didn't improve beyond 6/60, so I decided to go in. So here the vitreous doesn't have that much of exudates, but it's not a clear vitreous. The procedure is essentially the same. You clear the vitreous, taking care not to induce traction and not to induce breaks. And these low-grade endophthalmitis, you don't keep on waiting for weeks or months together. If it doesn't clear within a reasonable time, of course it cleared in the first 1 week but did not clear in the second week, that is the time when you have to take up for a vitrectomy, not beyond that. Here there was some synechiae, posterior synechiae, that also I am trying to release with this. Enter the anterior chamber, inject viscoelastic, and go with an iris repositor and release the synechiae, try to make the pupil round. All these procedures are possible and should be attempted during an endophthalmitis vitrectomy, because left behind this could gradually cause the IOL to slightly subluxate into the AC. So that is relieving the synechiae, again completing the vitrectomy, and then pulling out. Here I have pulled out the ports and then injected antibiotic. You can either inject through the port or pull out the port, pull out the trocar cannula system and inject the antibiotic and close the case. Wait for a culture report. You have already injected your choice of antibiotics. Look for the antibiotic sensitivity, and based on your culture report and on the progress of the case, decide on further intravitreal injections. Thank you.
Thank you, Dr. Thomas, for that very elegant presentation. We have about 8 minutes left with us. It stands between you and the star of the show, OPL. So if you have any questions for us, we'd be happy to take it up. If not, I have a question for you, Mahesh. Post-ERM peel patients are probably the most dissatisfied patients that you see. They have good vision, but they trouble you a lot. How do you tackle those patients?
I agree, madam, because unlike in RD or even macular hole, once you show that hole is closed, they are half relieved. But the ERM patients, first of all, you can't show much, because immediately after the ERM removal, the macula will not become normal. And their symptoms like metamorphopsia, anisoconia, all will persist. So I think it is basically a communication initially itself. That is the thing.
It might sometimes take years for the macula to go back to its normal contour.
The main thing is, if the patient has significant cataract and you do a combined surgery with ERM, they will be little more happy, because the cataract part will be taken care. They will see more bright. So that is one thing that I have. And if the cataract is also there, otherwise it is little difficult. Everyone might have encountered. Yeah.
So, rightly said, Meena, but I have a very high threshold for intervening. So I will not intervene just because ERM. So patient actually has to beg for surgery. You see, he should be troubled by the metamorphopsia. If he is troubled by metamorphopsia in his day-to-day activity, then only we intervene. If he's not troubled or occasional metamorphopsia, then don't go inside. Then you will face all these problems, what you're saying. So troublesome metamorphopsia, in case you do cataract plus, this surgery, these patients are happier. Although OCT will take, months and years to normalize, but metamorphopsia then will disappear. So high threshold for ERM.
Yeah, I think that is the best thing to do. What I do is that I show them the OCT and the fundus images at each visit. And subsequently, the patient comes back regularly for follow-up, and each visit he tells me, Madam, എൻ്റെ ഞരമ്പിലെ membrane എങ്ങനെയുണ്ടെന്ന് നോക്കണം, എനിക്കൊരു scan ചെയ്ത് നോക്കണം. So in the end, when you show them some changes in the OCT, they themselves ask, when can the surgery be done? So they have to beg for the surgery. That is the best thing to do. My question next is to you, sir. How do you follow up your patients on whom you have done vitrectomy? The macular edema can recur again down the line.
So you see, like I said, diabetes is a multifactorial disease. It's not doing a mechanical job of vitrectomy that takes care of his issues lifelong. So like you said, everything can have recurrence. So these patients, you have to pay attention to all those 5 things which I listed: the metabolic status, hypertension, lipidemia, sleep apnea, drug history, all those things have to be taken care of. So it's not that you do surgery and rest everything will be taken care of. And you are right by saying that it can recur. So you have to keep a follow-up in these patients. Although we have taken care of the tractional part or the pull part, but the systemic condition still remains, and he can definitely have. So such patients who have, say, edema after doing a vitreous surgery, then my threshold is very low for giving Ozutrex in such patients. So these patients, instead of giving the conventional anti-VEGF agents, I will give Ozutrex in such patients.
Prabhu, Dr. Prabhu,
Yes, ma'am.
most of these cases of PVR that you do beautiful surgery on, the retina settles on the table, but down the line you see that some of them do detach. Do you do anything in additional to your routine surgery to prevent the recurrence of PVR?
Especially when there's CD, man, that's the problem. When there's CD and you don't drain it completely, there's underfill of the oil. And post surgery, maybe a week, first day it looks fine. After 2 or 3 weeks, you can see the inferior retina again detaching up. So I think these two patients, now I think buccal vitrectomy is a good option, but now almost we are not doing buccal now. So maybe wait for a month or 2 months, wait, see whether the artery is worsening much, and that not much of PVR is there, then like maybe after a month or so, but not very early vitrectomy, because we need the second membranes to form, can go additional peeling, and then I think second surgery has to be very aggressive, madam.
In your most difficult surgeries, would you consider a two-stage surgery? Some surgeons do fill in with PFCL, leave the eye alone for 1 or 2 weeks, and then intervene again. By the time the retina has enough time to iron out.
Yes, ma'am.
What is your experience with that technique?
No, I've usually not much, man. I've not much experience with leaving the eye with PFCL for 2 weeks and doing. But during the first surgery, we try to salvage this as much as possible. But usually repeat surgery is after 15 days, a month. That time we go on for in case a patient needs a retinectomy, we do quite extensive retinectomy and do it.
Settle the retina.
Settle the retina.
The last question is for you, Thomas. We are seeing more and more difficult organisms to deal with. It is not the routine endophthalmitis that we used to see about 15 or 20 years back. We are dealing with difficult organisms. They are low-grade cases. You do whatever is possible, and then again they keep on recurring. And sometimes the same patient may have to undergo 5 or 6 surgeries, vitrectomies, before you can clear the vitreous cavity of the debris. What is your experience with these kind of organisms, especially Acinetobacter? That is, there has been several episodes of Acinetobacter endophthalmitis in our community.
I haven't come across that many cases, but if it is a recurrence, I always go for an explant, go up and clear as much as possible, then inject the newer antibiotics, Tazobacter, piperacillin, and try to keep following up the patient. But the second surgery, I always explant.
What is your take-home message? Most of us sitting here are probably cataract surgeons. I see very few retina specialists in the room.
Yeah, take-home message is always err on the side of endophthalmitis. Don't have a wishful thinking. If your patient presents with a drop in vision, if the patient presents with a pain, any sign of inflammation, which doesn't clear in a couple of hours, never hesitate to refer to your VR colleague. And if that takes time, always inject your primary antibiotics, vancomycin and amikacin or ceftazidime as the case may be, and then refer if it takes time. But always err on the side of endophthalmitis and not keep on believing that it is a task.
Are there any questions for anyone in the panel? From the floor?